Hervé Tarragano made a presentation last year as well, and he's back this year, and he is a gentleman we really liked last year. So thank you, Hervé. Well, don't worry, it's okay. Everything's perfect. Well, you need a microphone. So try to keep this short. It's going to be okay. Don't worry. Thank you very much. Well, thank you for the invitation. Please give a microphone to Audrey as well. Because since we're supposed to do this quickly, well, we're going to do it as a pair. I'd like to thank everybody for the quality of the lectures I've heard so far. They're exceptional. I've added Audrey Lacan to my presentation. She's a radiologist specializing in ENT radiology in Paris. And the question is, what pictures, what attitudes when the radios speak to us? I mean, this conference comes from what happened here last year. Because last year, someone from Auto Partner asked me a question about a treatment plan. I don't know if that person is here today, but that person asked about an orthodontic treatment for a patient who ended up having a sinus with the sockets bulging into the sinus. And the question was, can we move the teeth for an orthodontic treatment while the patient has virtually no bone on her sinus floor? And we worked on this, and a colleague sent me this pan X-ray. She's called Sabrina Oninsky. I think she went to Medina. And she said, what do you think? Now, maybe it's obvious to you, but at the time for us it wasn't easy. And I said, look, I don't know. I see that there's an impacted cuspid. However, here I believe there's a mesiodance on the scan. I don't know if we're supposed to do a scan. She said, are you sure? I said, yes, I think there's a mesiodance. So I referred the patient to Audrey. And we did a scan, and I couldn't find the mesiodance. I could not find it. I could not locate it. So I did a 3D reconstruction, and still I could not find the mesiodance. And really, the 3D reconstruction normally shouldn't miss anything. It simply looks at everything. So we looked at the pan X-ray again, and if you look closely, in radiology, people say, Edith Aujoyeux used to say, you see with the eyes of love, which means you don't necessarily see the things, but you think you see them because you know they're there. And you see here, this is the wing of the nose, and the same thing on the other side. So what I thought was an anatomical problem, and look, really, I've done this for 30 years, and I thought I knew, well, there was nothing there. It was simply the nose, which is actually showing clearer on the pan X-ray, and that's the reason why we say X-rays talk to us. Now, this conference I've also prepared thinking about artificial intelligence, and I just want to talk only about implantology. I want to tell you that radiographs provide information. There we have maxillofacial surgeons here, and it's important. I'd like to ask questions while Audrey provides information. This pan X-ray, can someone switch the light down, dim the light down? Thank you. Okay, there's no one there. So here, we can ask questions and ask ourselves, can we treat any patient from a pan X-ray? Yes, we can, but we belong to a family called doctors, although we're dentists, maxillofacial surgeons, radiologists, we're doctors, first and foremost. And you should be able to refer your patient towards a specialist for good management. On this patient, we could do orthodontic treatment, no, maybe yes, mesialize, etc. But I can ask myself questions if anybody has the answer. What can we do here? And here we look at the patient and we see on every side little stains here. Audrey, can you take a microphone? Well, does anybody have the answer in the room? Maybe I'm not the best person to provide the answer. Exactly, bilateral calcification of the parotid glands. So you should be able to provide an answer to that question. Another question here, pan X-ray, the patient comes to the clinic. What are we looking at? I'm not delivering a lecture here or interrogating you. This is an ameloblastoma. It's a serious lesion, and a maxillofacial surgeon should deal with that. Here, this picture, here we have an image, here up on the condyle. there is a metastasis in the mandibular condyle. Here we have calcifications. Here as well. So we don't know exactly. I mean, here this is the submaxillary gland. It could be the submaxillary gland, but it could also be a carotid calcification. It happens in this area. So, you can't miss radiological lesions, and that's why I say that radiographs speak to us, and we have to interpret them. Now, there is something here that is not highlighted, but can anyone tell me what this is? Exactly. And sometimes the styloid process, what does it do? Well, it becomes ossified. The stylohyoid ligament can become calcified. Here on this side, people complain of pain, stiffness on the cervical area when they swallow. When there is total calcification of the stylohyoid ligament, this could cause pain. And here the patient felt pain in the right-hand side tonsil. And the patient did not come to the clinic for this reason. He came to us, he had had surgery, he had beautiful surgery. No, I'm joking. There was awful surgery, the sinus is not well lifted. I mean, this is catastrophic. So I'm not going to go over the whole case, but every anatomical element is important, the condyle, the styloid process, etc. And when you know the anatomy, then you can visualize it, you can identify it more clearly and more easily. So don't forget the anatomical elements. And the most difficult thing to remember here is this one, the sigmoid fossa, whatever. Don't forget those elements. Here, there is something else which is important. This is a pan X-ray. You're an orthodontist. I'm a dental surgeon. I specialize in implants. Maxillofacial surgeons do surgery. And when you do a treatment, you have to be able to identify the lesions that may be an obstacle when dealing with the patient. Yes, you move teeth when you're an orthodontist. Yes, you place implants when you're an implantologist. But can I do surgery on a patient at any time regardless of the consequences and forgetting the radiological lesions? What's wrong with this patient? Apparently nothing. But the one thing that draws my attention is this little image in the sinus. Is there something wrong here? Well, we have a complete opacity of the maxillary sinus. The sinus is full, whereas the other one is empty. And here we have a little dense image. And here it shows better, and the scan shows in the cone beam we have sinusitis. This is the panoramic reconstruction of the cone beam, and here you see quite clearly that the sinus is full with a metal element here, ossification of the wall of the maxillary sinus, and the sinus is clogged. And there is aspergillosis here and aspergilloma, and we have calcifications, and we have aspergillosis in the right-hand side maxillary sinus. And if you look at the initial X-ray, you see something is wrong, but you don't know for certain what is wrong. Well, I'm going to show this again, and I'm going to tell you that because you do 3D reconstructions, there is obviously a pathognomonic image of chronic sinusitis, the thickening here of the maxillary cortical wall. On this side it's thin, on this side it's thick, and this is a sign that the sinusitis has become chronic. We were talking about muscles earlier which pull on the bone and allow the basal bone to grow in rotation with the famous pull. Well, here the mucosa, because of the chronic sinusitis, is being pulled on the Schneiderian membrane, and this causes thickening of the maxillary bone membrane. Here we have a pan X-ray. Okay, now it's clearer, obviously, it's here. Yes, exactly the same thing. We have a foreign body, a metal foreign body again, but the sinus is empty. It looks like the right-hand side sinus is full. It doesn't really show clearly on the pan X-ray, but in the CT scan you see the foreign body in the maxillary sinus. The maxillary sinus mucosa is thickened on both sides, but it's not really significant. So there is no significant sinusitis here around the foreign body. Another pan X-ray. What do we see? Nothing? Yes, no, sorry, again. Okay, I'll show you the 3D reconstruction. Look here. The sinus is full. It's clogged. There is something you always keep saying. You don't treat the radiograph, you treat the patient. Yes, that's right. Here, I would extract the tooth, not ask too many questions, look if I can do a sinus lift or not. You know, but it's interesting to look at a pan X-ray and to ask questions. You can't leave the patient like that. The patient has complete anterior sinusitis, the anterior ethmoid is filled, and the maxillary sinus as well. You know about sinusitis, you're aware of sinusitis. Anterior sinusitis, complete sinusitis, and if you look at the pan X-ray, yes, of course, there was something here showing that there was this maxillary sinus filling, but it wasn't obvious, whereas on the CT scan it's obvious. Yes, and the important image for us dental surgeons, or for you orthodontists, or maybe maxillofacial surgeons, or anybody belonging to the medical family, it's important to analyze the images. We're going to do this quickly because we don't have much time available. But here, Audrey, can you explain the picture here? So it's going to be quicker. On the ethmoid, the inferior ethmoid is separated by the middle turbinate root, and the anterior ethmoid, here we have the root that separates the anterior ethmoid from the posterior ethmoid, and it drains into the medial turbinate. So any sinusitis from dental origin will give an anterior sinusitis, and it will be different from the posterior sinusitis, which will drain into the superior meatus. So the first cause for anterior sinus are the teeth in the ethmoid. But what does it mean? It means that when you look at the pan X-ray, which is relatively hazy, you should not be tempted to be happy with the pan X-ray, and that's that. You have to ask for a complete maxillary examination, and you've all seen CT scans that will not provide a complete image of all the face sinuses, frontal, ethmoid, and maxillaries, and you can't do a diagnostic examination for a sinusitis if you don't have an image of the ethmoid, sphenoid, frontal, and maxillary sinuses. This is an illustration of what Audrey was explaining to us. This patient comes to see us after surgery, and he seems to be okay. For those of you who place implants, we have good limits on the sinus floor. You have opacity of both maxillary sinuses, but you know, it's hazy. 3D imaging post-surgery was not indicated, but still we did it. And what did we find? Total clogging of the right-hand side maxillary sinus, which was not there before the surgery, just as an illustration. This is something that Audrey really finds important. Yes, that's what we said earlier, to talk about implantology examination. When you do surgery on the maxillary sinus, you need to see the whole sinus. You can't simply take small images of the bottom of the sinus before you place an implant. And so I would like to remind you of the anatomy. The anterior ethmoid and the maxillary sinus are draining into the middle meatus. So here we have the middle turbinate. You have the meatus here, and it drains into the infundibulum of the middle meatus. So this area should be visualized before you do any surgery on the maxillary sinus. And if it's clogged, if it's obstructed, then you can't do surgery. Yes, that's what we were saying earlier. The anterior ethmoid, posterior ethmoid are separated by the middle turbinate root, and anterior sinusitis with the anterior sinus is clogged, and the dental origin is periodontal lesion, on number 6. This is what we find in most clinics with a small field cone beam. And if you look at the patient like this and you do surgery, no, I say I can't do surgery because of this image. I have a pan X-ray, I have a cone beam. The dentist is very happy with the cone beam. I can't do the surgery. Why? Well, because if you look at both patients, here you see just a small submucosal cyst. It's not pathological. The two sinuses seem to be empty. Same thing on this patient. You can't see really anything. But when you take the complete image here, both olfactory clefts were filled with hematomas. And here there is nothing. This is a perfectly normal examination, allergic rhinitis, but nothing else. So the left-hand side patient, we can't do surgery because we have to deal with the hematoma. On the right-hand side, everything is okay. Another example, if you look at the incomplete image, both sinuses are well aired. This is a bit thick, but okay. And if you took the whole picture, here there is the nasal polyposis with polyps in the nasal fossa. The maxillary sinuses are okay. but post-operatively it's not going to drain into the middle meatus, and this patient had an aspergillosis, aspergilloma, in the draining area for the maxillary sinus. This is a quiz. We have a huge sinus lift done by the dentist, and the patient comes to us, can we do surgery with a patient looking like this? Well, he went to a clinic, a dental clinic, and the dentist saw the patient and said, okay, well, you know, we're going to place implants, you have a sinus lift. And the patient says, no, I never had a sinus lift. And the patient says, okay, then I'm going to do a sinus lift, except that to be cautious, he referred him to an ENT specialist and a radiologist. And the radiologist sent us this picture, and it was not a sinus lift, it was a cematoblastoma. So here we have an ameloblastoma-like lesion, but it's a cementoblastoma. Maybe it's not malignant, but you know, you remember earlier we said what can we do or not do, retention patients, the ones who take care of themselves. Well, no, you can't, for legal reasons, do surgery on a patient if you don't know what was there before. Otherwise, you're legally responsible for everything. You're liable for everything. So you have to know the history, the disease, why the patient is like this, for what reason. Too many patients came to a clinic and asked for an endodontic treatment. And if you look at the X-ray, you find that there is a broken file in the tooth root. And do an X-ray before you do anything. Otherwise, you're liable. You're the one in trouble. And if you don't know, stay away from the patient. Now, this is typical. Here, I would do a cone beam systematically, and the cone beam shows me a 3D image with a 3D reconstruction of the root. I'm showing this. Why? Maybe you're familiar with this, but here, this gap here is the so-called Staphne gap cavity. Those are salivary glands that will cause a concavity in the mandible. It's not pathological, it's just salivary glands, accessory salivary glands, and they create a gap. And it creates a depression in the mandible. It's not pathological. You have to simply know what is pathological and what isn't. And that's the reason why we say X-rays talk to you. This is also something you're familiar with. We can go quickly. Now, what about this? X-ray, pan X-ray, you can see everything. And, you know, we're preparing a book, so if you have any interesting pan X-rays, please send them to me. This is a cabinet of curiosity, all the crazy signs. This is a post that went into the sinus. They wanted to extract the tooth, and the post went into the sinus. And obviously here we have to go in and remove it. There's so much you can find on an X-ray. This is a crazy picture. You have so many crazy things. So we said X-rays talk to us. What is this? These are carotid calcifications. The patient should go and have an SAT Doppler performed. So you're not a cardiologist, but when you see anything like this, please refer the patient to a cardiologist for an SAT Doppler. Now, this is rare. We have tonsil lithiasis, a tonsil stone. You do lots of cephalometric images. I don't. But what is this? Again, carotid calcification. So please do lateral cephalometry, because you can refer the patient to a specialist if you find anything wrong. Okay, so back to our topic. This doctor did a PhD on artificial intelligence last Thursday. His name is Raphael Benayoun, and his supervisor was Franck Moyal, one of my friends who worked at the Pitié-Salpêtrière Hospital. And in his PhD, we have the picture shown by Dr. Lesvernius earlier. And just for your information, deep learning, roughly speaking, is about reconstructing artificial intelligence from the neural networks imitating our brain. So we create intelligence from neuronal networks, same as the brain ones. And here we have data fed into the system, and the machine learning is when you teach the machine and you feed the machine. But it's interesting because many mistakes were made with artificial intelligence. I'll give you one example of a bias. And you have to be careful. In the US, they did, okay, we're going to look who in the hospital is profitable for the hospital and who isn't. And they did a table on appointment planning, and they looked at who came to the appointment, who came on time, and who didn't show up for the appointment. And they found that those who didn't show up for the appointments were black people. And they said, okay, then black people don't need medical care in the US because they never show up for their appointments. Artificial intelligence defined that American black people, Afro-Americans, did not come to the hospital and therefore did not need care. They were not assiduous, and the demand for healthcare for American, Afro-American people was not necessary. That's artificial intelligence for you. If you give the wrong algorithms to artificial intelligence, then your results are wrong. And the same for expenses in the hospital. They showed that people with low income never showed up and black people never showed up. And because both categories didn't show up, it means they didn't need care. So they defined that people who needed care in the US were rich, white people. You know, that's artificial intelligence for you. And we have a software, and the software no one knows about is Allison. It's not completed yet for caries detection. We'll come back to it. Regarding endodontic treatments, they have tried to assess pain criteria to find out when to refer the patients to endodontic treatment. It's not completed, but we're getting there. Periodontology, they try to assess what is going on, pan x-rays, codifying pan x-rays, centralizing them, and finding out a protocol to define whether it's a periodontal disease or not. We're getting there, but it's not completed. Periodontal surgery, we look at the x-ray to orient and refer the patient so when it needs to be treated quickly or not, to optimize patient care, to go faster. Implantology, it's the only one that is really doing a good job. We have a file with 12,000 implants to identify implants. That's okay. However, we still have to do deep learning matching to feed the information into the system and enrich the system. Orthodontics, well, you're the one who know about that. You're the ones who know. I'm not a specialist in aesthetic, okay. So what we really wanted to show today is to raise your awareness on conventional radiology, 3D and pan x-rays, and tell you that each x-ray has a story to tell. Maybe you will miss something, but there is always something in the x-ray. If you have any questions, Audrey, if you'd like to add something. Well, are there any questions? Thank you so much.